Welcome to the AES Professor's Rounds Epilepsy Surgery Case Studies. My name is Jill Hunt, Education Coordinator for the AES. Before we get started, I have a few housekeeping notes. This is a 1-hour interactive session and we encourage your participation. I will unmute your microphone so you have control. If you are not speaking, please keep your mic muted. You can also use the chat function for questions or comments. Click on the chat icon in your control panel. A recording of this case conference will be made available on the Training Continuity section of the AES COVID-19 Resource Library. Your professor today is Dr. Chris Skidmore, Associate Professor of Neurology and Vice Chair for Clinical Affairs in the Department of Neurology at Thomas Jefferson University. Welcome, Dr. Skidmore.
Thank you very much, and welcome everyone this afternoon. So I'm going to go over 3 cases today, not necessarily all epilepsy surgical related, but kind of illustrating various different points or kind of key features in different patients with epilepsy. So again, we want to make this as interactive as possible, so I'm going to stop. If you have a question, feel free to type it into the chat, and Jill will be assisting us in that, or go ahead and open up your mic and kind of ask a question. So let's go ahead and get started. So the first case is that of a 77-year-old female who 3 months prior to arriving in our emergency room developed seizures and a change in personality. And when you ask the husband and her 3 daughters about her change of personality, they said she's just not as sharp as she used to be. She was always a very, very high functional individual, always multitasking. So she was just not as sharp as she used to be. And they said she was having memory problems, but really had a problem kind of pinpointing exactly what those memory problems were. And then she started to have seizures within a few weeks of this kind of cognitive onset. And the seizures, we can describe semiologically as starting with right face and arm tonic/dystonic kind of movements. They were very brief, lasting only about 5 seconds, but she was having up to 50 per day, so very, very frequent. And they kind of started, and she saw a local neurologist out in the community who started a lacosamide and titrated it up to 200 milligrams twice a day. And then because she wasn't getting better, eventually kind of showed up in our emergency room because the family wanted to try to get to the bottom of kind of what was going on for her. And so I'm going to show you a video of her typical seizure. So I'll show it once and then we'll kind of play it again and talk about it.
She just had another one.
You happy with it?
I got.
Okay, does anybody want to, I'll show it one more time, and then I'm going to ask if anybody wants to kind of comment on what they saw.
She just had another one.
You happy with it?
Anybody want to comment? Any comments in the chat room, Jill?
Nothing yet.
Okay. So the first thing I see, and I'll say is right after, right there, if you noticed, her face pulled and her head kind of jerked to the left a little bit and her hand moved. And then after this, she has a much bigger movement where she gets a little bit of abduction of the shoulder and a little bit more of tonic constriction of the face. So we'll keep playing that. If you notice, the hand kind of had this dystonic posturing of the fingers. And so certainly the video matched what the family was describing to us. As you can see, she's able to talk throughout this, right? So this is a focal aware seizure. So she's able to talk throughout the event. But you could imagine if this is happening 50 times per day, it's going to be very disruptive. She happens to be right-handed, so this is occurring in her dominant hand. So it's going to be very disruptive to her doing things in her day-to-day life. This was her MRI. And I'll give everyone a second to kind of take a look at that. Is there any questions about the semiology?
Is it always a facial-brachial dystonic?
So that's a great thought, right? So we have this focal tonic and dystonic, and so Could this represent facial brachial dystonic seizures, associated with the LGI1 limbic encephalitis? So great thought. It's immediately what we were thinking. I guess what goes along with that?
The memory.
Right, so the cognitive dysfunction, right? Implying that this is more than just the focal seizures. So that's one. The age of onset, she's 77 years old. So typically new, focal onset seizures in a 77-year-old, you're going to be thinking there typically is going to be some kind of structural abnormality or some, inciting event that's going to be causing these seizures. So that's great, yeah. So facial brachial dystonic seizures is what we were thinking. So then we got an MRI of the brain, and I'm showing you the coronal flare images. And I think it's important, here's anterior, here's posterior to orientate ourselves. It's always important when you're looking at the hippocampus, and you're going to be looking at lots of hippocampi as epilepsy specialists, is you're always trying to decide, one is the volume of the hippocampus itself, but then the second thing you're always trying to wonder about is the signal, and specifically on T2 weighted images like FLAIR or T2. And a good frame of reference is to compare the signal in the hippocampus to the signal in the insula. They should be roughly the same. Some magnets, some MRI machines, you'll see artifacts because they're not properly set up, where you'll see like one whole hemisphere brighter than the next. And so it's always good to kind of compare the hippocampus to the insula. If they're both bright, it's probably an artifact of the machine. Obviously, that's not an absolute, but it's just a good reference guide for you. So when we look at this, does anybody think that there's any signal abnormality? So we took a long peek at this, and we kind of went back and forth. We were debating whether we thought, here, this is amygdala, this is a little bit of hippocampus. We were debating whether there was a little bit of increased fuzzy signal here in the right hippocampus. But ultimately, we felt that, for the most part, this represented a normal MRI. Because we were concerned about limbic encephalitis, we did get contrast images, and I'm showing the contrast axial image here. The only thing we did find is this small meningioma outside, just anterior mesial of the left temporal tip, which we thought was completely incidental, and it hasn't changed since we found it. So that was the only incidental finding that we found. So we thought that this was a normal MRI. Here's the thing, when we looked at her EEG, she had no spikes. Even during those ictal events, there was no abnormality on the EEG to suggest that these were focal seizures. She had a MoCA score of 21 out of 30, which is significant. She got 0 out of 5 on recall. She got only 1 out of 5 on calculation. And again, this was a very high-powered kind of executive level person prior to the onset of these symptoms. And she had poor letter fluency. We did do spinal fluid and had normal routine analysis. And we got a CT of the chest, abdomen, pelvis because we were concerned about an autoimmune cause. And the only thing we found was a little nodule, 4 millimeters, in her left lower lobe. She was a smoker back in her 20s and 30s, but had quit smoking for a good 40 years at this point. So does this change your thoughts? Does this still fit with facial brachial dystonic seizures?
Only the semiology, but the rest doesn't really support it.
Okay. And so if you actually look, so she did actually have facial brachial dystonic seizures, secondary to an LGI1 autoantibody, which we tested, and hers was significantly elevated. If you look in the literature for these facial brachial dystonic seizures, you'll see reports of ictal changes or the dystonic events without ictal changes. And again, because it's a very focal motor seizure, very small geographic region, it's possible that you could miss this on scalp EEG. So the normal EEG, I don't want you to be dissuaded by the normal EEG. The MoCA score obviously goes along with that. There's more of a cognitive dysfunction than just focal motor seizures. You can have normal CSF in an autoimmune encephalitis or autoimmune epilepsy. So you can have the normal analysis. We would hope to see some elevated white blood cells, but it's not seen in all cases. And often CT chest, abdomen, pelvis, that's looking more for the paraneoplastic ones. and often would be negative. And facial brachial dystonic seizures, LGI1 limbic encephalitis, is not one of the autoimmune syndromes typically associated with a tumor. So we were not expecting to find one, and ultimately did not. So then when you look, what are the presenting symptoms of LGI1 encephalitis and facial brachial dystonic? And the majority of them is actually seizures, whether it's facial brachial dystonic seizures, just regular focal seizures. There have been some descriptions of tonic-clonic seizures. So a good proportion of the problems are seizure-related. About a quarter of them present with memory deficits, and about almost 20% of them present with behavioral changes. So she kind of hit multiple quadrants: the facial brachial dystonic seizure, the behavioral changes, and that memory deficit that the family was complaining about and that we confirmed on MOCA testing. So sometimes it's seizures at first, sometimes it's the cognitive changes followed by the seizures. This is a great kind of table out of a seminar in neurology article from 2005, really describing the paraneoplastic and autoimmune syndromes that can be associated with epilepsy, and just in general, the paraneoplastic and autoimmune syndromes. And it's important to remember that LGI1 is one of the plasma membrane receptor autoimmune syndromes. And so that goes along with Casper, with NMDA receptor encephalitis, the GABA-B receptor, the GluR5 receptor. Why is that important? Because when there's a plasma membrane target, these individuals typically have a very good response to clinical treatment. And in this case, immunotherapy with steroids and/or IVIG and/or typically rituximab. And so the plasma membrane targets tend to respond very well to treatment, whereas the cellular mediated targets, the ANNA syndromes 1 and 2 and some of the other cellular targets, they tend not to respond as well to immunotherapy. So fortunately, the facial brachial dystonic seizure patients fall in this plasma membrane category. So how common are autoantibodies in epilepsy? And this was a nice study done several years ago by Dr. Brenner et al. In 2013. And they wanted to look at a whole different variety of epilepsy patients. They broke them out to 2 cohorts, what they called their clinic cohort. So these are patients that had been followed in their clinic. So these are ongoing epilepsy patients that had had epilepsy for a number of years, compared to the newly diagnosed cohort, which are new patients coming into the clinic for a new diagnosis of epilepsy. And they were wondering, is there a difference of prevalence of these autoantibodies between the 2 categories? And so as you can see here, they checked a whole series of targets, including the potassium channel, the calcium channel, GAD65, NMDA, the glycine receptor. And if you look, there really was no statistically significant difference between these 2 groups. There was 26 total patients in the kind of follow-up patients and 20 in the newly diagnosed epilepsy patients. And then they compared this cohort of epilepsy patients to completely quote-unquote healthy normals. They compared it to individuals with neurologic disease not secondary to an autoimmune condition, such as stroke, for instance. They looked at other autoimmune diseases, and then they combined that cohort as well. And as you can see, when they checked these antibodies in this much larger cohort, they only had 1 total patient turn out positive, indicating that there is an increased rate of these autoantibodies in individuals with epilepsy. And it's approximately 11% of patients with epilepsy have autoantibodies. If you have an unknown cause for your epilepsy, that rate goes up to about 14%. And so this is not insignificant. This is a significant portion of our patients that can have one of these autoantibodies. But the overwhelming majority of patients with epilepsy do not have it. So then how do you decide when you screen for these autoantibodies? And this is just some general guide that many people in the field feel would warrant then thinking about doing the autoantibodies. And that's this term explosive onset epilepsy. So onset of epilepsy, completely refractory from the very beginning or very challenging to control initially, that may or may not be associated with limbic encephalitis. Major neuropsychiatric symptoms at presentation, any autonomic symptoms at presentation, the presence of a viral prodrome prior to the first series of seizures. If you definitely have positive CSF, obviously MRI changes with limbic encephalitis, and a current or prior malignancy. So these are the things that we then screen as we're kind of meeting new individuals with epilepsy and trying to decide, okay, if they have this risk, one of these risk factors, this might be the patient population that we should appropriately screen for these autoantibodies. So in my patient, she was initially treated with IV steroids and IVIG, and then was transitioned over to prednisone 30 milligrams daily. She became immediately free of seizures. The facial brachial dystonic seizures stopped. She was actually taken off antiepileptic drugs, and when you look in the literature, there's good evidence that AEDs do not treat the facial brachial dystonic seizures, but the immunotherapy does. So we took her off the antiepileptic drugs. Her cognitive function stabilized to maybe mildly improved. It did not significantly return back to normal. She's still complaining of some cognitive dysfunction. I've tried a few times to kind of completely get her off of steroids, which I was unable to. Every time I would get down to around 10 milligrams every other day of prednisone, her facial brachial dystonic seizures would come back. So we've now transitioned her to rituximab so we can stop the prednisone, and she's actually been on a stable dose of rituximab now for over a year and doing well. And so again, it just highlights that this particular disease type, one, responds really well to immunotherapy, two, tends not to respond to AEDs. So it behooves us to make sure we pick up these patients very quickly. And again, once you see that seizure type like that, you should immediately be thinking about it in the right patient population. So any questions about that or that I can answer?
I have two questions.
Sure.
Okay. So number one is hyponatremia in the literature was mentioned to be with like LGI1 cases. Is it a consistent finding in most cases? That's question number one. Number two is how do you decide, for how long do you keep the rituximab?
So great question. So hyponatremia is definitely a very common phenotype, and especially in the voltage-gated potassium channel antibodies, before we broke it out into the LGI1 subtype. If you look at that whole category, there was a very high incidence of, and I can't remember the exact figure off the top of my head, of hyponatremia. These tend to be older individuals, and they do develop hyponatremia. With LGI1 encephalitis, there can be hyponatremia as well. I can't remember the exact percentage off the top of my head, though, but it does occur. How long you treat, I would, unfortunately, we don't have a lot of good evidence-based medicine to guide that decision. Most individuals will try to treat at least for 3 to 6 months before trying to kind of wean off immunomodulatory therapy. And so, we've tried on 2, I think, or 3 separate occasions, spaced out by anywhere from 6 months to a year, to kind of wean this patient off of immunotherapy. And every time her facial brachial dystonic seizures have come back. So right now for the rituximab, we were thinking about leaving her on rituximab at least for several years, probably 2 to 3 years before we think about trying to initially probably reduce the frequency of the administration of the rituximab, and then eventually trying to get her off of that. But there's really no, unfortunately, good evidence-based medicine on exact protocols to follow. At least as of a couple of years ago, the Mayo Clinic was trying to run a large clinical trial on this to kind of gain some insight. I don't know where that stands at this point.
Thank you.
Okay, let's move on to case number 2. So case number 2, a young woman, 38 years old, with epilepsy, and she kind of has this indescribable aura that she has trouble kind of explaining to you. And then she would have focal impaired awareness seizures. They last anywhere from 60 to 90 seconds. And she was having, on average, about 1 to 2 per year. And she was on oxcarbazepine at a decent dose. And she previously had failed levetiracetam, phenytoin, and lamotrigine. And when she came to our attention, it was because instead of having the focal impaired awareness seizures 1 to 2 times per year, they actually were starting to increase in frequency, and she was getting them, once every 2 to 3 months. And so because of that, and the fact that she's failed numerous medications, it was decided that it was time to do a surgical evaluation for her. Here's her MRI. So the top pane, and it's a little bit older MRI, but this is a coronal T1 image, volume acquisition, and here's the corresponding FLAIR image here. I'll give you a second to look at that. And so again, if we look at the volume of the temporal lobes and the brain itself, the brain volume looks appropriate. The temporal lobe volumes look appropriate. The amygdala are symmetric. Now getting into the hippocampus, I don't see any definitive atrophy comparing left to right. And I don't see any definitive focal atrophy in other locations. And then we didn't appreciate any FLAIR T2 signal abnormality on her imaging. So we thought that she basically had a normal MRI scan. Go on to the next. And here's her video. So this is a little bit older, 2007. But I'm going to show you the video, and then I want you to tell me, is this a focal impaired awareness seizure, or is this a focal aware seizure? And then we'll talk about the features. Reaching for the seizure button.
You okay? She's not talking. Hello. Hi. How you doing?
You said not sure. I'm not sure.
Can you clap your hands 2 times for us? Good. Can you tell us where you are? Good. And what's your name? Tree.
So what do you think? Is this a focal aware, focal impaired awareness, and how would you describe this seizure?
I would say this is a focal aware seizure.
Okay.
Because she initially had there was an arousal where it seems like she felt a seizure was coming. She pushed the button, and then she was able to obey commands. I mean, she followed, like she clapped her hand when she was asked to do this. So her awareness was not fully impaired. She might be a little aphasic. That's a different story.
Okay. And she was a little bit delayed in some of her responses, right? And so I think if you look when the nurse comes in initially, let me just get back to the video when the nurse comes in the room. Okay, so initially right here, the question is, does she immediately respond?
You okay?
She's having some head nodding, but that wasn't a no motion.
Hello. Hi.
And then she starts to attend to the nurse right there.
How you doing?
And then she's kind of rubbing her eyes. She kind of seems a little out of it and certainly is slow to respond, right? So it's difficult sometimes to decide is something focal aware or focal impaired awareness, even when you have somebody coming in the room and doing testing. So she's right on this cusp of, she's not certainly crisp and probably normal responsiveness that she normally is, but she's also not fully loss of awareness. So she's kind of in this gray zone. I agree with you. Did anybody appreciate any automatisms? So I didn't think there were any automatisms. I thought otherwise this is a pretty bland seizure, kind of pushing the button and then the nurse coming in the room. So it doesn't really help us, unfortunately, this seizure, to kind of try to help figure out her epilepsy that well. Well, here's her EEG. And this is just a representative example. Here we have a transverse chain across the temporal regions linking the sphenoidal electrode, SP2, which is on the right, and SP1 on the left. You can see here's a right sphenoidal spike followed by this kind of burst of kind of sharply contoured activity, about a theta alpha discharge here that slows down, and then more typical appearing sphenoidal spikes here and here. So she would have these runs occasionally, and she had right anterior temporal sphenoidal spikes. So that was her interictal EEG. And you can see that without the anterior temporal electrode here in your AP montage, your standard kind of temporal chain, you don't really see that. You would have missed it. So this also highlights the value of using either a sphenoidal electrode, or in this case, T1 or T2 or FT9 or FT10 in the 1010 system would have provided some additional information that you would miss if you were just doing the standard 1020 montage. And then here's her seizure, the seizure that we just looked at. So I'm gonna walk through it. There's a whole series of slides, and then we'll come back and kind of talk about it. So this is right here what we marked as a seizure onset. So you can see this heralding spike here in the right sphenoidal region. And I'm going to just walk through the EEG, and then we'll come back and kind of talk about it step at a time. So this is the first page. And these are consecutive pages. This is the next page. Give everyone a second to look at that. Next page. Okay. So let's go back to the beginning. Anybody notice anything? Anybody want to hazard a guess as to where the seizure started? Red boxes aside. So I mentioned already, she's got this heralding spike in the right anterior temporal electrode here, the sphenoidal electrode, followed by this increase in rhythmicity with some spiking thrown in the delta range. By the time you get to the next page, it picks up in amplitude to be larger rhythmic theta spiking that you can see here. And so it reaches this theta frequency discharge within 30 seconds of onset. By the way, now you can finally start to see it probably clearly here in the standard AP temporal montage. And we keep going along. You then start to see it devolve into this rhythmic delta, which you can appreciate here. We go to the next page. Still kind of reading through the artifact. There is still some rhythmic delta there. But then here, all of a sudden, now we see this diffuse delta that's generalized. And as we go to the next page, you'll see that continue. And then eventually, more normal appearing background starts to come back here. Anybody else want to highlight anything else? Okay, I'm going to walk through one more time. Now I want you to ignore the EEG. Pay attention to the EKG channel. So she's kind of going along at about, 1 beat per second. Still going there. A little bit of probably some artifact here in the EKG. But then she develops a sinus pause. She's got a junctional rhythm that comes out here. And it's not until the next page that starts to come back and our heart rate comes back. So this is an example of ictal asystole. She developed the ictal systole, probably started right around here somewhere. There's a little bit of probably a junctional rhythm here. So she had 1, 2, 3, 4, 5, 6, 7, this is 10, 12, 13 until she starts getting a more normal appearing rhythm back. So about 12 seconds where she was her heart stopped. And that explains this diffuse delta that we see, right? You would not typically expect from a very exquisite, very focal right temporal lobe seizure, you wouldn't expect to see generalized slowing. You could get generalized slowing, diffuse slowing like this after a secondary generalized tonic-clonic seizure or a focal to bilateral tonic-clonic seizure. But you wouldn't expect to have that degree of slowing after a typical just right temporal lobe seizure. And so lo and behold, what we find and what we often ignore is we often ignore the EKG line, and she developed cardiac asystole. It's very easy to ignore the EKG because we're just so focused on looking at the cortical patterns. It's why at our institution, we actually try to put the EKG channel in the middle of the recording to force our eyes to kind of recognize it. And so this individual had cardiac asystole secondary to her seizure. Any questions about the EEG or the EKG rhythm? So the question is, what do you do about this? What do you do? What does everyone want to do? Do we have to treat the cardiac asystole? Do we just move forward with surgery and do a right temporal lobectomy? What do you think?
Interrectally, it was showing a low amplitude fast activity intermingled with spikes, or
Yep.
Yeah.
Back here.
Did they look further into the MRI to make sure?
We
there
did.
isn't
It was
any-
so. I guess it's your concern. Could there be like a cortical dysplasia?
Yeah.
Yeah. So we were looking at the neocortex, and when we went back and stared at it a whole bunch, we could not convince ourselves that there was anything abnormal in the right temporal cortex. But that's a good thought, right? You see these faster frequencies usually associated with a neocortical dysplasia. So we went back and looked at that. Good. So we decided, we said, first off, we have to treat her heart, right? Because if she's going to have an asystolic event, which each of her seizures. And I want you to look at the video again. If you notice right before the nurse comes in, and when the nurse comes in, she kind of is nodding her head. That's actually this, it's essentially the hypoperfusion. She was actually syncopizing at that point. So if you notice, she's kind of
You
flushed,
okay?
and she'll have her head nod a couple times. That's actually because she was losing muscle tone. She was perfusing her brain.
Hello. Hi. How you doing?
And then she kind of rubs her face. And so we put in a cardiac pacemaker for her. And then lo and behold, she had these quote unquote focal impaired awareness seizures that she was reporting to us, and came to us because they were increasing in frequency. And after we put in the cardiac pacemaker, she only had her auras again, and she no longer had focal impaired awareness seizures. And so we went from thinking about doing a surgical workup and perhaps doing a temporal lobectomy on this individual to treating her ictal asystole, and now she was back to only having focal aware seizures, and we actually put off having brain surgery for her. And this is rare. I've seen reports somewhere about a few percent of individuals will have cardiac asystole. So it's very rare, but it's something that we can't afford to miss. And so I know that when I was a fellow one time on a weekend, I kind of was quickly going through EEGs on a kid that I was covering for the weekend, and was so excited to see the seizure to look at all the EEG. I neglected to look at the EKG and realized that the child had ictal asystole. Luckily, though, on a second review prior to the kid leaving the hospital, we were able to pick it up and make sure that the child was treated. So the debate is, when do you put in a cardiac pacemaker? In talking with our colleagues in electrophysiology, cardiac electrophysiology, I think that's a little bit debatable. If it's a 2-second pause, probably not. If it's certainly 10 seconds or more, but there's really no good evidence, again, as to when you should or should not put a cardiac pacemaker in these individuals. But certainly then you need to, consult cardiac electrophysiology and kind of have a multidisciplinary discussion around that. Fortunately now, most pacemakers are MRI compatible. It was an issue in the past where once you put in a pacemaker, then you lost the ability to do additional MRIs, which obviously becomes important for some of our patients with epilepsy down the road. So any questions about that?
I'm wondering if those patients, do you ever consider implanting them and making probably making them more of surgical candidates. So we treat the underlying cause, and then their heart, they won't get any asystole.
So yeah, so right, the issue is, do you treat the epilepsy or do you treat the cardiac asystole? I think, so first of all, the cardiac arrhythmias and the asystolic events are more often reported in the dominant left temporal hemisphere, temporal lobe, than the non-dominant, but you can see it on both sides. Obviously, even in the best temporal lobe epilepsy surgical case, right? If everything is all pointing to one spot, seizure freedom at 1 year is 80%. You know, if you look at the studies, and if you look at, you know, Sam Weeb's study from Canada, when they did the randomized controlled trial, it was, you know, closer to around, you know, 60, 65% if you looked at the intention to treat analysis. So even in the best temporal lobe cases, you know, it's only at 80% at 1 year, and at 10 years, multiple data from our center, from Cleveland Clinic, numerous centers around the country and the world, you know, 50% of the people are still seizure free. So unfortunately, epilepsy surgery doesn't cure somebody. And then my concern is, if we're not curing them and we're just going to wait and see what happens with seizures, and we haven't treated the cardiac risk, you know, that's my concern. So I would lean towards treating the cardiac risk. If they continue to have seizures where they're losing consciousness and losing awareness, then absolutely proceed with a epilepsy surgical evaluation and treatment. Does that make sense?
Yes, I was wondering if it's just like the pacemaker is just a temporary measure until the epilepsy is sorted out. But
yeah, no, I mean, I think the pacemaker is a temporary measure, but again, a not insignificant number of patients continue to have seizures after epilepsy surgery. It's still much, much better than additional medications. That's why we do it. But I still think you got to address the cardiac issue and then continue to address the epilepsy issue.
Of course. Thank you very much.
Yep. Any other questions about this? Okay, let's move on to our last case of the afternoon. So now, this is a 49-year-old gentleman who started having seizures when he was 10 years old. And so he had seizures as a child. And the way he told it to me in clinic was that he had seizures when he was 10, and then he outgrew them. He outgrew them when he moved into adolescence, and essentially in his 20s stopped having seizures, came off his medicine, had been living independently his whole life, working a normal job, and had no known kind of epilepsy risk factors. He was on no medications when I met him, but he was on phenobarbital as a child. And he recently got married. And they did not share a bed prior to getting married. So they never shared a bed prior to him getting married. And I'm going to show you the video of his seizure. And he had this seizure on the first night of his wedding, on his wedding night, the next night, and pretty much every night thereafter. So let's watch that. And so you describe to me what kind of seizure this is, and kind of what's the salient features, and then does it offer any potential lateralizing or localizing value? So let's take a peek.
Remember the color blue. Remember the color blue.
Remember green. Green. Turning to his left. Turning to his left. It's okay. Just moving oxygen. Okay. Kiss my hands.
And now he's post-ictal at that point. So what did we see? Anybody want to describe what we saw?
We have a guess in the chat of hypermotor frontal lobe seizure.
Okay, so hypermotor frontal lobe seizure, certainly frontal lobe seizure from sleep, lots of motor phenomenon. Was there anything specific about the different components of the seizure? So when I look at the seizure, one of the first things that we'll notice is he kind of starts to stiffen up, and then his head will turn towards his right, and then he literally spins over in bed. And so that is the term we would use is to describe as a versive seizure. And it's an extreme version of the versive seizure where literally he's forcing his head so far that he kind of continues to, his body follows it and he keeps flipping over in the bed. That is consistent with onset in, or the semiologic zone is the, in this case, the left frontal eye field, right? So the left frontal eye field is driving his head and eyes to the right and forcing him to turn all the way over in bed. And then it's followed by, after the versive component, a bilateral asymmetric tonic seizure, which would suggest then that the seizure discharge spread to the mesofrontal region in the supplementary sensory motor area. So let's take a peek at that. And so that basically, with the right version and then the bilateral asymmetric tonic, we were suspecting a kind of left frontal focus based on this seizure semiology. Any questions about that video? Okay. And just to show you that, here's one, again, during, quote unquote, during the daytime hours, we were doing an ictal SPECT injection. So we basically kept him up all night, made him sleep during the daytime because his seizures only occurred from sleep. And this time, not so much the versive movement, but more just the bilateral asymmetric tonic movements. So kind of arouses from sleep. And then he's going to start to stiffen up a little bit. It's not as pronounced as the first video I showed you. But you can kind of appreciate he's kind of starting to stiffen up his body a little bit. And again, this characteristic.
Oh, nice. Okay.
So remember, I told you that this gentleman was seizure-free from adolescence all the way through age 49 and had a seizure the first night of his wedding, you know, the next night, the next night, the next night. So what do you think happened? Is marriage epileptogenic?
I guess they were missed.
Right. So it turned out, again, he spent his entire life, he never had a roommate. He slept in his bed, you know, by himself. And because they only happened at night, when we asked him about this, he just said, you know, we asked him, hey, did you ever wake up with like your sheets all over the place and stuff knocked off your dresser? And he said, yeah. He goes, but I just always thought I was just a rough sleeper, is what he called it. So in all likelihood, he's probably had seizures, you know, for his entire lifetime. And it's only because he got married and started sharing a bed with somebody that fortunately it was recognized. So it's kind of interesting, you know, and again, some patients don't recall that they have a seizure because this happens in the middle of the night. He's just going to go back to sleep and he'll have no memory of the event in the morning. So this was his EEG. So this is his interictal EEG. And really the only thing that we saw that we were definitive about was this little tiny CZ spike here, which corresponded to a C4 spike here and a little bit of a C3 spike. So this CZ spike at the midline, initially when we looked at it, you know, if you take a quick glance, you go, maybe that's EKG, but then you look, it's actually not time locked with the EKG. The time is variable. This one kind of coincides directly with it. So this was reliably felt to be a CZ spike at the midline. And then when he went into the seizure, the first thing that you notice is that there's this paroxysmal fast right here at CZ that very quickly then spreads bilateral and becomes kind of generalized. And as I move forward to the next page, you'll see that kind of fast activity continue. Beta slows down to a, you know, more diffuse rhythmic alpha, and then stopped. So again, based on semiology, based on the EEG, we now again are growing our kind of evidence bank that he probably has frontal lobe epilepsy, and most likely, given the semiology, left frontal lobe epilepsy, probably somewhere close to where the left frontal eye fields are, in the middle frontal gyrus. Unfortunately for him, his MRI was non-lesional. He had an FDG PET scan that was normal, and he had completely normal neuropsychological testing. And so at the time, we talked to him about the need for an intracranial implant to kind of confirm the localization and talk about surgery. And he unfortunately was not interested at that point. It, felt like, he had been living with this his entire life and didn't want his, to have brain surgery. And so he kind of put it off and got lost to follow up. And this is actually a case from when I was a fellow. And so then I moved on to a new job. So I don't unfortunately have long-term follow-up on him. But it does highlight this point of, it's important to ask about patients. We have many of our patients live alone, and you're always wondering, are they having more seizures than they realize at home? And, every once in a while you'll bring somebody in the epilepsy monitoring unit and you'll capture a bunch of seizures. And it really drives home the point that many of these individuals are probably having seizures that they're not recognizing at home. Any thoughts about that case? Any questions?
So are like gyratory seizures mostly like frontomesial? Is that what the thought process?
I'm sorry, I missed the very beginning of what you said.
Are gyratory seizures mostly thought to be mesial frontal?
Gyratory meaning that versive movement?
Yes, they turn mostly as if they complete a full turn.
Yeah. Not necessarily. It can be driven all by the frontal eye fields in the middle frontal gyrus. So it's definitely a frontal lobe seizure. I have not seen data that it's definitively mesial frontal.
Okay.
The bilateral asymmetric tonic component would suggest more than spreading to the mesial structures. Are you aware of a specific article?
No, I just remember we had a patient before that we discussed different localization for a gyratory seizure.
Yeah.
For this patient was a extension of a chronic sinusitis that caused an abscess and was mesial frontal. So we were discussing the localization.
Yeah, and I think, remember, where the seizure starts is very different than where the seizure spreads. And so whether it's truly starting in the mesial frontal region would spread out to the kind of frontal eye fields. But that behavior, at least from my understanding, is really driven more by the activation of the frontal eye fields.
Yeah, makes sense.
More of a, obviously on the dorsal lateral surface.
Thank you.
Yep.
Thank you.
Other questions? All right, well, that's the cases that I wanted to present today. I wanted to kind of make sure I got you guys out on time. So thank you very much for participating, and I hope you found this useful.
Thank you very much.
All right, have a good day, everyone.